Okay, good day everyone, and welcome to today's TK-VetKids webinar. And thank you all for joining us. My name is Sylvia, and I'm delighted to be your host of today's section. For those who may be new to the TK-VetKids, we are the development and innovation of veterinary endoscopy solution, providing high-quality endoscopy technologies and to support the clinical diagnosis, the minimal invasive procedure worldwide. We are honored to connect with the healthcare professors from different countries through this academic exchange platform. As a part of today's commitment, TK-VetKit has launched a webinar platform series as a platform for the knowledge sharing. Through these sessions, we will invite specialists from all over the world to share both their clinical insights and the practical experience, helping veterinarians integrate endoscopy in their daily practice with greater confidence and efficiency. Today, we are honored to have Dr. Ronald van Noort as our speaker. Dr. Ronald van Noort graduated from Utrecht University and became a diplomate of ECVIM-CA in 1998. He has extensive experience in companion animals interdiction through the university and the practice setting in Europe and the United States. His main clinical interests are gastrointestinal disease and endoscopy. We are honored to have him today with me to share his knowledge and experience. After these presentations, we will have a short interaction Q&A section. If you have any questions, please feel free to type them in our chat box or use the raise hand function. Now, Dr. Ronald, please begin the presentation. Thank you.
Thank you for the nice introduction, and the joy is completely mine working with you together. Problem is, endoscopy is my favorite subject, so I have so much to tell, and many times I speak too quickly, so if it's too quick, please try to slow me down. That's a disadvantage of a webinar. You don't have interaction with the audience, but I'm glad that you all joined, and yeah, let's see what we can do. Endoscopy, is it a toy or is it a tool? Well, for me, it's definitely a tool, but it brings a lot of joy, so yeah, it's also a toy. These are the earlier endoscopes for humans, not really very elegant. If also quite dangerous, because if this patient starts vomiting, he might choke, or the doctor might get some vomit over him, so it's not ideal. Fortunately, nowadays we have excellent machines with a perfect view and a nice compact arrangement. Especially with foreign objects getting out of the stomach, I have used more efficiency with the scopes than with these very fancy fair machinery. I hardly ever win something with this, nobody will, I think. But yeah, this reminds you a little of the foreign object retrieval from the stomach, but that's more efficient. Fortunately, I don't have to send my patients often to the surgeon. Most of the times I can get the foreign object out myself, I hope. The advantage is, if you have a little bit experience, you can be asked to, let me see if I can get rid of this one. Yes, you might have the luck to be invited by other specialists to do anything else but dogs and cats. And this was a toucan. I did some birds of prey, an owl, a chicken, but also hyenas and gorillas, and even a little rat. And dolphins. Those are very nice things to do. But let's keep on the theory. Endoscopy more or less means looking inside something, and that something can be a natural opening in the body, mouth, nose, ears, and so on, or it can be a man-made opening, like with arthroscopy, laparoscopy, or thoracoscopy. Nowadays, it's also possible to do an endoscopic examination of the stomach and then go through the stomach wall into the peritoneum. That's quite heavy. We don't have any experience with that in veterinary medicine. Endoscopy can basically be done in two ways, either diagnostic to see if there's anything wrong with the mucosa, take a biopsy, check for obstruction of passage problems, or maybe find a foreign object which was not recognized up until now. And it can be a therapeutic. Those most of the times are the foreign objects. Probably many times a little bit of an emergency patient, but not always. For an object in the stomach, as long as it's not really sharp, it can stay there for quite some time. But you can also think about dilatation of strictures of the esophagus or the colon or even the duodenum. Removal of polyps. Unfortunately, that's not so much, not many times possible, because in human medicine, the polyps have a very small stalk. You can just cauterize the stalk and the polyp is gone. But in veterinary medicine, dogs and cats, they most often have a very broad stalk, so you can't get it out entirely get it out. So that's more or less a surgical procedure. Placement stomach tube is also possible, and injections in the mucosa. You can understand that if you want to give an injection, you can't have a needle going through your working channel of your endoscope, but this is a tube where the needle is inside, and if you push on this knob, then the needle goes out and you can give an injection or take a biopsy, an aspiration biopsy. Like the lady already said, it's a minimal invasive atraumatic technique most of the times. It gives you the possibility to inspect the mucosa of the oral cavity, the larynx, maybe the nasopharynx, the esophagus, stomach, duodenum, colon, and if you are lucky, you can also go from lower colonoscopy through the iliocolon sphincter and have a look in the ileum. With a rigid endoscope, you are you can't do much more than the esophagus, or even not completely the esophagus. The descending colon you can inspect in the nose, ear, and urethra in females. Flexible endoscopy is much more elegant, but has a slightly less brightness of the lamp. The light is more strong in a rigid endoscope, but with a flexible endoscope nowadays, you have a perfect view. The basic principle of an endoscope is in all the cases the same, flexible fiber optic or video. You have your handset and you either look through the eyepiece or put a camera on it. With the camera attached, you have a lot less light, so not always very practical. You have a suction valve, an air and water blow valve, and a working channel. And with these knobs, you can turn the tip of the scope in 4 ways normally. This is just trying to see how the machine is comfortable in your hands, because you're going to be half an hour or an hour busy with it. So you really have to find a nice way to not tire your fingers and your thumb, and still performing all the tasks like blowing in air, sucking out air, feeding the forceps in, opening the forceps in. So in the beginning, it's really a lot of work, which sometimes will be divided that assistants take biopsies or so, but it's just a matter of getting a routine in that. The working channel depends on the thickness of the endoscope. You can imagine that with a very small endoscope, you can't get a huge diameter of working channel. TK-VET has some small endoscope, but still a large working channel, so that's good. And it's important because if you remember high school, the volume of a sphere is 4 divided by 3 by P by R, the radius to the 3rd power. So if you have a biopsy of 0.7 millimeters, the volume will be 1.43. But if you have a 1.2, so not even twice as much, you have a much bigger sphere. So your pathologist will be excited if he gets this amount of cells, or less enthusiastic if you get only this amount of cells. So the larger the biopsy channel, the bigger the forceps you can use, which is definitely advantageous. So, for instance, TKVet has a 5.8 millimeter endoscope, so it's very small. It's still a 2.8 millimeter working channel and blown in air and water, so that's good. Let's see. Well, it's not this far already, but in the future maybe this will be reality. Probably not. So either when you have a dedicated room to do your endoscopy in always, you can have a nice tower. I don't know how else you will describe it, but with everything attached and everything clearly visible, and the endoscopes, you really have to keep them hanging on the handpiece. Otherwise, if you keep them rolled up in the suitcase, that's not good for the endoscope. But if you don't have the luxury of a separate special room, you can have a portable thing, and then you only need the little device, which is a screen, source of light, and it transforms the images to the screen. So that's a very nice compact thing with a small scope. So that's very nice. Probably in the beginning, when you have a new endoscope, you want to do it in every patient you see, but it's only very rarely the first exam. For instance, for an object in the healthcare is definitely the first examination endoscope, although in that case you might want to take an X-ray before to see if there's any indication for perforation before you put in the endoscope, just to protect yourself that the owner can't say that you caused perforation. But normally you have to work up the patient and conclude if it's the best choice. Now, one of the best things to work on a patient that is the history, and that's a very neglected thing in veterinary medicine. If you put endoscopy for me on the first spot as the most likely things, nice things to do, history taking is definitely the second, because it's such a nice game, kind of a detective game to see what's going on. History taken has been regarded as the greatest of all medical arts. That's really true. You can teach a gorilla to do an ovarian hysterectomy, but asking a good history is very difficult, because every answer, every click of a wheel will give you another insight, will think in opposite direction. With an owner a little bit reluctant to give a lot of information, it's difficult. An owner who has already made a diagnosis itself by Google is very difficult to give good, trustable history. So it is very difficult, and you really have to take your time for it and see it as a detective game. So see where the little elements of truth are, and how you can handle that. But that's very difficult. So proper exam will be step-by-step signalment. It's always nice to have a dog with diarrhea, and it's for instance a Lundehund. Then you have to think maybe it's a protein-losing enteropathy, but of course not every Lundehund has protein-losing enteropathy, or not every protein-losing enteropathy dog is a Lundehund. Same as not every German Shepherd with diarrhea has EPI, or every Chow Chow with vomiting of blood has a stomach tumor. But still, it's nice if you remember if there are any special things in the breed you have on your table. Again, the history, general impression, then you make a problem list, you examine the dog or cat in general, and maybe a specific organ, GI tract, for instance. You make another problem list, and then a differential list for each problem, and then see what is the next step is that endoscopy or something else. Also, think of medication and diet. Maybe prescribed by yourself or from a colleague from another practice. If they prescribe, for instance, a hypoallergenic diet, so that's in a hypoallergenic diet, this is not a hypoallergenic diet. So again, make sure that you know what has been done previously and make a good problem list, because yeah, you can say the problem is the lines, but I think the real problem is the flat tire, and probably that tire is also flat. So yeah, difficult to see what's the biggest problem. Some small examples: a dog, female, neutered, 10 years old, vomit since 12 days. The heart rate was very low, 50, 65. Capillary refill time higher than normal. So one of actually the first step would be blood work, and that shows a low potassium and high, low sodium and high potassium. So very indicative of Addison's disease, which was proven by the acid estimation test. Cats are not food, proper respiratory regurgitation, and the first step in regurgitation will be an X-ray and not endoscopy, because with endoscopy, first the esophagus is already dilated because of the sedation, and second, you blow in air. So mega esophagus is not an endoscopic diagnosis, it's an X-ray diagnosis. Right here you see that there is enlarged between here and there, the white line, that's in mega esophagus. Kitten 6 months, diarrhea with upper GI scopy, but good history revealed that it was more with tenesmus, blood loss, frequent little amounts of stool, so more likely in colitis. So we didn't do the endoscopy, we fasted the cat for 2 days and then did the colonoscopy. So again, the best way is to take biopsies when you have your endoscopy done, but it's not always the first exam you have to do. And yeah, it's a little bit awkward to make the diagnosis of worm infection with endoscope. Is a little overkill. So try not to be trigger happy, and in the beginning, either you are afraid to start working with the endoscope, or you might be so eager to use your new toy that you don't follow the rules. So be careful. What are the indications then for endoscopy? In upper GI tract, mainly dysphagia and regurgitation, but first X-ray. Chronic vomiting is the most common cause. Hematemesis, sometimes melena, but then you have to consider that you might not be able to reach the place of the bleeding. If you have an ulcus in the duodenum, you might see it, but if it's in the jejunum or ileum, you probably won't find it. Hopefully, an ultrasound will give you an indication if there is an abnormal intestinal wall. Chronic small bowel diarrhea, of course, and you see things like foreign objects, dilatation of stricture, and sometimes placing in a percutaneous stomach tube, but that's not done so very much sometimes. Indications for colonoscopy from behind: persistent hemiplegia, tenesmus, urging, mucus on the stools, blood on the stools, chronic large bowel diarrhea, small amounts, frequently per walk and per day, fecal incontinence, dysgeusia, strictures found by either radiology with contrast agent or ultrasound or rectal palpation, and foreign body in the colon. It also happens. This was a dog with a very abnormal colon. It was all the way from the rectum up until the biliary colon, sphincter, was all this. We felt it, of course, with palpation. And this was such a good dog. We did the endoscopy, colonoscopy standing up without the sedation, just only patting his head. And we could go all the way to the ileocecal valve and take biopsies, and yeah, this was all malignant lymphoma. The dog did quite well for a couple of months on chemotherapy, but unfortunately, in the end, he had to be euthanized. GI endoscopy can be done after 12-hour, 24 hours fast. don't say that they can't drink, but that sometimes when people get the assignment to don't feed the dog, they also refuse to give them the water. That's not good. And please mention specifically that they are not allowed to eat, but also don't let them take too much grass, because it's so frustrating if you go into a stomach or colon and you see only huge amounts of grass. It's difficult to get all things out, and it will take many minutes to get it a little clear vision. So specifically warned, and also not to eat grass. Colonoscopy, 2 or 3 days no food, if that's possible, if it's not a young small kitten or a dog or so. Oral cleaning solution by mouth. Enema is possible, but the substance in the enema can damage your scope, so most of the time we don't do that. And really flushing is difficult, because you really have to flush a lot. And in cats, your colon valve is not really strong, so if you put in too much fluid in the rectum, it will flow through the duodenum into the stomach and into your esophagus, and hopefully not in your trachea. But if you have luck that they did prepare the dog well, and you see the ileocecal valve, the cecum, and that can have many different appearances. Sometimes you don't see this one at all. Sometimes this one is completely covered by mucus. This is the same patient, and now it's much bigger, and the cecum is smaller. So that's a variety of possible pictures of this area. And if you are lucky and the scope is small, you can go through the colon valve into the ileum. Well, how does it go in practice? You start your endoscopy by preparing the endoscope, see if everything works, checking for dirt, for moisture, for lesions, for little abnormalities on the scope itself, and check also your forceps, your snares, or your instruments. Check if the mobility of the tip is forwards in every direction good. For flushing during endoscopy, you have a little bottle on your endoscope normally. Please use only demineralized water. Check the insufflation and suction if it works, and you can do that most effectively by putting a little water in a small bowl, put your endoscope tip in, and then close the water and the air valve and see if there's enough bubbles. Because it's very frustrating if you are in the esophagus and you don't get the standard esophagus. That can be because of the esophagus is too firm, too hard not to dilate, or it might as well be that you don't blow in the air at all. So if you have to decide that when you are in the dog already, it takes a lot more time. So please check before if there's sufficient bubbling or if it's not at all. Then if you are in before you go into it, the endoscope into the patient, you have to white balance it. That means that you have the tip shining on a white surface, and then the computer will adjust the light source and the color, and then you have the optimal color. Always intubate, preferably. Prevent red flare. That means that you are in the mucosa, and if you keep on pushing, probably it doesn't work that well. Just go back a little and try to find the center of the lumen and see if you can get a lumen site. If necessary, flush some water. And again, don't keep on pushing, because you can damage the mucosa. Little advice that can save you a lot of money is indeed use the demineralized water, because you can see the demineralized water, because this is a bottle attached to the endoscope, and this is calcium deposits after only half a year working with it. So you can imagine if this is also in your channels of your endoscope, it's not a good situation, and it might block your channel, or you might have to face a expensive repair of getting a new air tube in. So use demineralized water, it's much safer. If you are starting then with the endoscopy, you can see the normal oral cavity here quite well. Maybe you can also direct the endoscope always to almost to the epiglottis, then flip them over 90 degrees or 180 degrees and see if you can enter the nasopharynx like this. If you see it, I can show yes. So with your endoscope into the mouth, by the epiglottis backwards flip, and then you can inspect the nasopharynx. Don't always have to do that if there's no vomiting or so, if there's no dyspnea, but especially in case you quite often see malignant lymphoma in this area. Then you go into the esophagus, the upper sphincter, body, lower sphincter, into the stomach. The corpus folds are most of the times directing into flowing in the direction of the entrance. So if you follow the folds, you probably have to go to the entrance. Big problem is that if you blow in too much air, then all the folds disappear, and then you have just a balloon with tension, and that definitely will block, will lower the venous return. So you really have to take care of that. And it's just sometimes not so easy to find the entrance because you don't see where the corpus folds are going to. You can make the jigging maneuver, I will show you later. You see the lesser curvature, the pylorus, and then hopefully you can get into the duodenum and see the villi, the bowel, the entrance of the bowel duct into the duodenum, and see if there's any content in there. Always need sedation and anesthesia in general, except for every now and then a colon we can do without. I even did some cats without sedation colonoscopy. We have to remember that we always have to use the left lateral recumbency, because then your pylorus and the entrance will have the most air, and you can more easily find the pylorus and the entrance and pass the pylorus. Again, do not cover the abdomen or check regularly if there's no distension of the stomach, because you really can blow in a lot of air, and that definitely compromise venous return, and in theory the stomach can rupture. We see that many times, fortunately, that it is possible. When you push in the endoscope, most of the time you don't see so many changes. The only thing some dogs and cats react when you try to pass the duodenum, then many times there will be a temporary increased heart rate. The stomach of a dog is more or less oblique from the esophagus, cardia, fingers, body, entrance, from left to right. The stomach of a cat is more elongated and a little bit more in a straight line. With cats, sometimes you really have to see that you, for your idea, have to go the other way and to go to the entrance. If there is air in the stomach when the dog is in left lateral recumbency, the air will be in the entrance pylorus, and that's where you want it to have. If it's on the other side, then the air will remain in the corpus, and that's not useful, because in the corpus you can always find your way, but in the entrance it's difficult. Little aside, you see if it works. So if you have your endoscope coming into the esophagus, let me see what it depends on, into the esophagus, corpus, entrance, pylori, and duodenum. If you put the dog in a left lateral recumbency, then now you see that all the air is in the entrance and the part of the stomach, part of the corpus. So you have much more air in the antrum, which makes finding the pylorus a lot easier. So always on the left side down, but there's always, of course, an exception when you have a foreign object in the stomach and you can't get it through the pylorus or through the cardia. Put the dog in another position, either sternal or on the right side, to see if that makes a smoother passage from the stomach back into the esophagus. Sometimes it really helps if you're trying for minutes or for hours to get it out, and once you put it on the other side, it's a piece of cake. So again, it's always a possibility. Yeah. Sometimes there's a very abrupt color change between the pink corpus and the more white antrum on the side of it, and the back flip. So if we go in with the endoscope cardia, corpus, antrum, you see the folds, you see there's a beginning of the cardia, the beginning of the antrum. If you go in further, then you really have to see here is that's the curvature, and then below that it's the antrum. So the antrum gives us a hyena with a very distinct separation between the corpus and the antrum. But that's normal, but many times when you take biopsies from this, it's not abnormal. The experienced endoscopist probably would say this is abnormal, and that was indeed. There's this focus on the lesser curvature. In dogs and cats, it's very, or many dogs, very suggestive of tumor, carcinoma, but not always, fortunately. So in this case, it was just an infection. This is the back flip. So you go into the corpus, flip the endoscope maximal to one side, and then you can see the endoscope entering the stomach by the cardia, and many times you can see big masses or lesions around this area, which you totally miss if you go in straight. You would expect that if you go in straight, that you could see something left or right of the cardia, but that's not always the case. Many times there can be really big tumors or ulcers without being noticed unless you do the backflip, so that really has to be done. Then go through the pylorus, antrum pylorus into the duodenum, and see how things are going there. It's always wise to do this quite rapidly, get a view of the cardia, the fundus corpus, the backflip, and then go on to get into the duodenum, because the longer you are struggling in the stomach to get through to inspect them, the less likely it will be that your pylorus will dilate and will accept that we go into the duodenum. So, and also when you take biopsies, and if they bleed a little bit too much, then you get a loss of sight view, and then you can't find at all the pylorus. So quickly inspect the stomach, and then go first to the duodenum, take your biopsies, and then go back and take your biopsy of the stomach later on. So again, biopsies. You always have to take biopsies, because a macroscopic view is very seldom really re-diagnosis. You really have to take your biopsies. Sometimes within stomach, also on the lesser curvature, you might get some experience out there. Well, this must be a carcinoma. That's the only thing you can more or less recognize without pathology. But again, taking biopsies will be useful to know it for 100% sure. An upper GI endoscopy is always, of course, the esophagus and the stomach, but also the duodenum. You should also include the duodenum, even if you think that it's really only vomiting because of stomach problem. Please do also the duodenum, especially in cats, because cats are notorious that they do everything different than dogs. With the dog with an duodenitis or inflammation of the small intestine, there will be most of the times too much fecal material or diarrhea. but in the cat it might, well, that they don't have any diarrhea, but they just vomit. So vomiting is definitely related to duodenitis in cats, less than in dogs. You always take the biopsies from the stomach and the duodenum, and include the duodenum also in a stomach problem. How do you take a biopsy? Well, that's a thing you have to practice day and night for the first couple of weeks, probably, when you start doing endoscopy. You really have to know how to hold the handle, know how to work a biopsy. Yeah, it's difficult. It's just a matter of experience, and it will come, but in some people quicker than in other people. Find a representative spot, position, and if there are no abnormalities, still, of course, may take biopsies. And in general, we take 4 to 8 biopsies of the duodenum, 3 biopsies of the antrum pylori, 4 or 5 biopsies of the lesser curvature, 4 or 5 biopsies of the stomach corpus, and 2 or 3 of the pydia. That's your standard amount of biopsies you take. So find a representative spot, position the scope about 4 centimeters proximal to the spot, slowly insert the forceps, and keep the end of the scope pointing towards the center of the lumen, in the middle of the lumen, so you don't feed your endoscopic biopsy through the endoscope directly into the mucosa. It won't perforate, but it can hurt the stomach, and it can cause some bleeding. So try to make sure that when your forceps is exiting the endoscope inside the patient, that he's not pushing directly into the mucosa, but pushes into the central lumen. Then try to make a flip of the endoscope so that you will be perpendicular to the mucosa. Open the forceps on the mucosa, push it a little, take out the air with the other valve, and then with a quick, brisk movement, get the biopsy and take it out and put it in a piece of cloth or in a formaldehyde. Please take care that whenever you feed your forceps into the endoscope, you always have to keep the forceps closed, because if it's open, it will ruin your kidney, your working channel, and that's a very expensive repair business. So always keep the forceps closed when you push it into the mucosa, into the working channel, and also when you're taking it out with the forceps in it. When your endoscope will be completely bent, then the working channel will be a little bit smaller in the curve. So if you need to take a biopsy with a completely bent endoscope, you better stretch the endoscope first, let the forceps come out a little bit, or half centimeter or so, and then make the complete flip if it's necessary, and that the scope is bent, then you don't damage your working channel. Okay, and then take your biopsy out and put it in a formaldehyde. You can also put it on a slide, squeeze it, and take a bio and have a look at after coloring of the cells. But yeah, the only thing you really get to see, which you will miss with your histologic biopsies, is giardia. Because if you get a pathology biop in formaldehyde, giardia will die and go to the bottom. So the pathologist probably won't find your giardia, and with a smear it might as well. So biopsies is much better. The standard endoscope can only reach the flexura caudalis of the duodenum, but there are some new developments. 2 balloons. We have nowadays double balloon endoscope. There are 2 balloons there, and by sucking out the air and blowing in air, you can more or less slide your whole small intestinal over the endoscope, so you can reach with this system the colon. It only takes about 3 hours, and the endoscopes are 15 millimeters, so that's way too large for our dogs. There's also a possibility submarine capsule endoscopy, not too small dog, and cats probably are not small enough to get this, but they have to swallow this, of course, and then chew on it. When it's in the intestinal tract, the stomach, it will give pictures. It will send that completely every couple of minutes out. But you can't take biopsies, and you don't know exactly where you are. So it's veterinary possible. There are some firms, if you write them a letter, they will send you a machine, and you will return it, and they read the machine and give you a report. But yeah, in my opinion, if you can't take biopsies, yeah, then the main thing what you can diagnose is if there are any bleeding lesions. But again, you don't know exactly where, so it's not my favorite. Yeah, then we always have the problem experience. It's not a very difficult thing to do. You just have to have a lot of experience. And if I can become an endoscopist, then anybody can become that. But yeah, you just need a guiding hand, guiding look over your shoulder to see what you are doing wrong or what you're doing not what you're doing right. In human medicine, a specialist GI can only be a specialist when he has at least 130 supervised endoscopies, and special nurses will have 6 to 12 months of training just to know the drill. For instance, you can't use every medication because there will be some medications that decrease the tonus of the lesser esophageal for instance. But there are also medications that increase the tonus, and they are sometimes not very nice if you have a closed lower esophageal and you can't go into it. That's not a big problem. A bigger problem might be the morphine like medication that can increase the tonus of the pylorus, which makes it sometimes impossible to enter the stomach, to enter the duodenum. So the learning curve of an endoscopist is depending on your own skills, your spatial orientation. Do you know where you are? Perseverance. Can you continue if it's not working right, especially in for an object? Sometimes it's very frustrating. If you have any experience, and preferably guidance by an expert, but again, yeah, that would mean that you still have a specialist looking over your shoulder, and that's not always possible. So webinars by TKVet and workshop will be very nice, but they're also not always possible. We did some workshops in Saudi Arabia, it was really very nice, but the present situation, it's not possible. But then it's nice if you have a small kit that you can show and can use either for GI or nose. And with a compact system like this, it's a really nice working your way through the endoscopy. What is a successful endoscopy? If you've seen all the necessary areas, if you recognize any abnormalities, taking sufficient amount of biopsies and sufficient quality of biopsies. And again, most of the forceps are one-time use forceps, disposables. But of course, veterinarians most of the time use it 5, 10, 20 times. That's if the biopsy pipe is not good anymore, you really get lousy biopsy. So your pathologist will mention a lot of trauma, a lot of shear trauma, so you really have to take another biopsy. Again, it's sedation, so make it as short as possible, so an acceptable time, and not without causing harm. So don't make lacerations, don't take deep biopsies and so on. And you never know what you're going to find. So you can't do endoscopy, in my opinion, with just one forceps and an endoscope. There are many practices who have second-hand machines from the hospital, and with one or two forceps, that's probably not wise, because it's a little waste of time and money if there's something in the stomach and you can't get it out because you don't have enough instruments. So multiple forceps, flexible and rigid, especially rigid in the esophagus if there's an object rather firmly attached to the mucosa. You sometimes need stronger forceps than the flexible ones you put through the endoscope. Then you don't put on rigid forceps parallel to the esophagus. Loops, baskets, dilatation balloons, magnet. That's not. You can't buy that prepared in the endoscopy shop. You have to make it yourself, and it's really very handy many times. You need to get the air out, because if you can't get the air out, you have the restriction in the anesthesia, but also waking up is less comfortable. Sterile tubes, screws, needles, and so on. You have a whole list of what is handy and what is necessary. So with forceps, through prongs to get foreign objects, those don't work that well, in my opinion. Snare is much easier, much better. Basket is also nice. Foreign objects with a sharp tooth. This is very nice for small objects. You can put it on the foreign object and then retract the line, and your jaws will capture the small object. Dilatation balloons, big or large, large or small. Cytology versus the needle. And this is especially very handy in the foreign object. If you have a foreign object in the stomach, you put this thing on. It goes in the stomach, and when you go out, this will flip over and becomes a protective hood to put your endoscopic found foreign object in, for instance, or glass or sharp material, and then you have a safer trip back to the esophagus and out of the mouth. It is a very handy thing. It will be rewarding to have such a thing, because it helped me numerous times to get it for an object out, which was not possible in another way. But if it's in the esophagus and very firm, sometimes you need those horrible big things to get it out. Even these kind of terrible large things. A company which has eye for the customers might sometimes make special things. This is a scope with 2 working channels. It's very rare, but sometimes TK can make special things. Sometimes you really have to be inventive. This was a dog had iron ring and loop, and it was bigger than the biggest forceps, so you can't get out by forceps. So we made a second working channel next to the scope, with a little tube with sellotape glued to the endoscope, put it in a little thread of what do you call it, rope, and then enter the stomach, shoot the rope out of the second working channel, grab it with the forceps, guide it through the ring, and then with that loop you can pull this back into the protected foot, and you can get it out. It's very nice. So you really don't use too much force, because the force will come to you, but be inventive like a MacGyver. You could make anything work with just temporary normal things. So be inventive. That's the main thing. This is something we already have said. Lateral recumbency. Please use a mouth gag on the left upper and lower canine tooth, because otherwise they will bite your scope every now and then. That's again a lot of money. Cautiously insert scope, and don't push it with power. Insufflate air, and again really check. And also, when you are in the middle of an endoscopy and you have the impression that you can't inflate anymore, just take the scope out, put them in the little basket with water and see if it's blowing in air, because it can also happen during an endoscopy. So every now and then, if you don't trust it, take them out and see. In cats, the last third part of the esophagus is a smooth muscle, and you really see that. That's a different appearance than a dog, so you can say what kind of animal you're in. Cardia normally is closed, but again, it depends also on your sedation. It interprets if there's redness, increased vasculature, bleedings, and so on. Biopsies of the esophagus are not standard because the esophagus is a very firm mucosa, so you can't take biopsies that easily. If there are lesions, that's a different story, but if it's relatively normal looking mucosa, it's a waste of time to try to get the biopsies. And again, don't over distend the stomach and the intestinal tract, because that really gives a lot of problems. So quick inspection, then go through the pylorus to the duodenum, and then on the way back you take your biopsies of your stomach. Again, macroscopic view is rarely decisive. The tumor on the annulus is, but this is different. If I ask the audience which situation would you prefer for your own intestinal tract, then most people would say this, because this is bleeding and it's looking terrible. This was an acute gastroenteritis. This was malignant lymphoma. So you can't see the difference, the severity of your abnormality. So really take biopsies. That's always the best way to do. This was the lesser curvature, the annulus. There you see the cardia, the scope entering, back flick now. So this is cardia, annulus, lesser curvature, and the antrum pylori. And this is very suggestive of a tumor. This is very, very hard material. Normally, if you push your forceps here, it's flimsy, it bends and moves away. This is very hard and firm. It's solid material with an ulcus. And yeah, this very, very, very suggestive of an tumor. That's it was. This one. Instances that you don't get a diagnosis with endoscopy is if it's a functional problem, if there's abnormal motility, hypersecretion, or breast border enzyme defects. Those things you can't diagnose with your histology. Or if there are abnormalities outside the mucosa layer, because with the biopsy you don't take a biopsy of all the layers, of course, because then you have a hole. So if it's very superficial, or normally the superficial abnormalities relate to the mucosa, but the muscularis and the serosa are not feasible to take biopsies. But again, the majority of the abnormalities will be in the mucosa, because there's the whole immune system of the intestinal tract. So yeah, changes will definitely be in the mucosa. So again, the maneuvers, and then we can take nice biopsies. Even with the naked eye, you can see this a nice long filling and this very short. You can see that with the fiberglass endoscope is not so good. Then this distinction is not really very easy to make. But with video endoscopes, you definitely can see the difference. And these are not long fingers, but little stumps. And this is a nice, really nice picture of very large normal feeding, but it's completely normal situation. But it also depends on how much air do you blow in. If it's a lot of air, then you'll see less protruding villi. But this is normal appearance. This is an exit of the bowel duct in the duodenum, and the ultrasound found that there was an probably a stone and sedimentation, and it was only in the opening. So we decided, well, we're going with the endoscope, and with a screw zeroing needle pushing in here and some force that we eventually, in the end, managed to get it out. It didn't take that long, but the quick was a little new for me, and that's again one of the situations with endoscopy that even if you have 40 years of experience, you still see every now and then something that you've never seen before. And the more experience, the more you know what to do with it. So it's very strange when you had 2 or 3 of those patients within 2 weeks. 40 years I haven't seen them at all, and now in 3 weeks 2 or 3, and all from the same practice. So it's strange. But they did well. We got the stone out, and it was sufficient. So that's nice. This is a pious patch. It's also in the beginning you think, oh, that's strange, and that's a tumor. No, it's just a normal pious patch that there's supposed to be there. These are small, not elongated villi, so you don't see the nice long fingers that like see life with the Psychostome movie. But they are very dull and small. And you see lymphangiectasia, increased filling of the lymph vessels centrally in the villi. So this was definitely villus atrophy, lymphangiectasia, protein enteropathy. Very small villi. So only superficial biopsies, not a complete full thickness, then you really have to take surgical biopsies. But again, the vast majority will be in the mucosa. Advantage of an endoscope versus a laparotomy will be reduced anesthesia time, far less invasive, no problems with healing of surgical wounds and so on. You can pinpoint more clearly where is an abnormality, and if you want to repeat the procedure, it can be done the next day or the day after that. And that's not so handy in a laparoscopy. Advantage of a laparotomy is that you can see the whole intestinal examined, but if you have doubts, you can also ask the sonography to get an impression of the intestinal tract. Full thickness biopsy, not always advantage that it can do. And again, you can also see other organs and maybe take biopsies from those. Possible complications in endoscopy can be perforation, but it's very rare. Damage of large blood vessels is possible. Reduced venous return, anesthesia-related problems. Those things can occur, and if you have done an endoscopy and you don't take out the air, then you have a air-filled stomach, which might distend more and get a volvulus. So please take out all the air to wake up the torsion. Mucosal bleeding. I've never done checking the blood clotting in dogs and cats with endoscopy. It's very rare that there is some bleeding in the intestinal tract with a coughing problem. So, transmission of pathogens, that's a possibility, and humans are, of course, very, very strict. Veterinarians are strict and want to reuse the forceps probably. Well, that's not entirely true, but it really helps if you can show the owner some of the pictures you made and letting you see how the condition of the esophagus is after a couple of days for an object there, for instance. That's really dramatic. I'll show you in a minute. So emergency endoscopy mainly for an object in the esophagus or nasopharynx or trachea. For an object in the stomach, most of the times can stay the night. For instance, if they call in the middle of the night or late in the evening, if there's any bleeding and feeding tube can be necessary to do that quickly. This the esophagus is strange organ that it really regenerates quite poorly. Lesions, especially in the distal part, tend to cost a lot of time to heal, and if they heal, sometimes they will get strictures, so you have to go in again and dilate the stricture. So the faster you are with endoscopy, the better it is. Well, a whole variety of things. The most strange things you can get out of dogs and also cats. Completely spoon. Yeah, but it will definitely will not pass through the endoscope, through intestinal tract, of course. Also smaller things. This was a red clip, and one leg was in the duodenum, the other was in the entrance, so it really stuck. Very small thing. And this is the infamous foreign object. It was a chewing bone, rawhide. And let me see if I can yes. It was there, and the veterinarian suggested to the owner, "I'll leave it there, it will digest." No, that's definitely not the case. There is no digestion in the esophagus. So it remains there for 4 days. Then they sent it over to us because it was really deteriorating. Let me speed it up a little bit. It was too firm attached to the mucosa to get it out with forceps through the endoscope. So now we have a rigid forceps. And even that one has some problems. We knew that it was a rawhide, so there were no sharp edges, and then you can use a little bit more force if you have experience. If there are possible sharp parts on it, like in a whalebone, then you can't pull like this, and you really have to make sure there are no obstacles in the pathway. But now, finally, you get it out, and preferably go before you put the forceps in. Take a look if you can see around the foreign object that this was completely squeezed on every side because of the longevity of the foreign object there. So it's out, and then we go back, and then you get a horrible side of the mucosa. This is almost necrotic, almost perforating. This dog really needed a lot of attention afterwards, but he survived. He healed and didn't even get a stricture. Okay, that was the main thing I had to tell you. I hope you could follow everything I said too quickly. There are always other endoscopes. This is a small endoscope for bladder and nose and so on. It's a really nice setting. And you can also see nice things like a shot of urine in the bladder through the opening of the ureter and ureter. So that was all I had to say. I hope you are still awake or still present. Are there any questions? Hello.
Thank you, Dr. Ronald, for your excellent presentation. Thank you so much. Now, so we can move on the Q&A section.
Yes.
Okay, so if you have any questions, please type them in the chat box, and the Dr. Ronald will answer them shortly. Or you can raise your hand, or in the Q&A section is all these functions is okay. We can receive your questions. Let me check.
Or if they have no questions now, they can also send them later on by email, and then I'll give them
yes.
an answer.
Yes. So it's okay if they, maybe because of the time, but if they can also contact you after the meeting via your email, I think. Let me check let me check the box or the section. Oh, there is a Q&A. Can you see the Q&A box?
No, where is it? No, I don't have a Q&A section. Where should I go?
Okay. Sorry, let me check. 他是不是停那个停止共享载？ Hi, Professor. Can you see the Q&A? I think have a red dot on it. It is on our function, like just beside the. We have different buttons, and I think there's a button with a red dot. Can you open it?
No, I don't see a red dot.
Okay. Let me check. Maybe if you close the sharing, you stop sharing. Maybe. Okay. So I can. Okay. Have you seen this? Okay. Let me check. Let me check. My screen. I think. Okay. So, can you see this? See the screen, the Q&A sections on the screen.
Yeah, but that's all in Chinese.
Yes. And the first one is from the Jeffrey Lee.
Okay.
Can you see the questions on the screen? No.
Yeah, only see Chinese.
Okay. Let me check. So I will tell you the question. Okay.
Yeah.
Okay, so let me stop sharing now. Okay, so the first question is from Jeffrey Lee, and the question is: I'm the manager of a veterinary clinic in China, Hong Kong, and we don't have an endoscopy yet. Could you tell me what size endoscopes is generally needed for the cats and the dogs?
Yeah, well, that's 5.8 millimeter endoscope from TK-VEC. That's a very nice endoscope with a sufficient length of 115 centimeters. It also has a valve for air and from suction. So you really need to have an air and water supply and suction. But that's all contained in that 5.8 scope with a 2.8 working channel, so that would be great for dogs, cats, large dogs. If we use 1.50 meter, that's most of the time sufficient. It's always nice to have a bigger scope because that's in a big dog easier to maneuver and maybe even get more biopsies. But if you want to restrict it to one endoscope, then definitely the 5.8 is good. The majority of the other brands don't have the 5.8 millimeters with the 2.8 working channel. So that's a very nice example of TK-VEC that they have. Yeah.
Okay, that's a good answer for our audience. And there's a second question: what mix of medication do you usually use? Do you generally use for the anesthesia?
Yeah, that depends on, but most of the time we use medetomidine with propofol IV. And yeah, that's more or less safe for most of the animals. If they have a cardiac problem, sometimes we do something else, but the anesthesiologist we have under practice. But the general patient can be sedated with medetomidine and anesthesia with propofol and gas anesthesia.
Okay, that's nice. And that's the number 3 question. And this participant is asking: is it the 2.8 flexible endoscopes is good for the cystoscopy, or the rigid one will be better?
2.8 flexible scope is easy for female dogs and male dogs. The rigid one is only for females. So if you have male dogs, yeah, you really need a flexible 2.8 endoscope. Then you can see the urethra, the part of the prostate when he is entering the urethra. You can see the dorsal membrane in the urethra. So yeah, it's really a nice machine.
Okay. I think your answers is very match up to his question.
Okay.
And I think it is very clear.
Okay.
Let me check if there's other questions in the chat box. Let me check.
No, stayed rather close to 1 hour. It's not too much longer.
It's okay. Yeah, thanks for your patience.
I hope it was not too rapid speech, but hopefully people will understand the majority of it.
Let me check. Do you have any other questions? You can ask Dr. Ronald directly, or you can raise your hand. If the time is not so match up, you can ask the questions via the email of Dr. Ronald after this meeting. I think you already have answered all the questions from there because it is very clear in your presentation. A lot of experience and also the knowledge is very clear in the presentation.
Nice.
Thank you, Dr. Nora. Thank you so much for the insightful and engaging presentation. Now we have gained a valuable perspective on what is an endoscopy and how to use it to our work. And I also learned about the proper handling and also the basic operations technique in our clinical practice. And also thank you to everyone who joined us today. Your participation means a lot to us. If you have any other questions, please feel free to contact us or the Dr. Ronald after the meeting. And our full recording of this webinar will be uploaded to the YouTube very soon. Thank you again to join us today. Have a great day, and we hope to see you on our upcoming webinars. Thank you so much. Thank you so much, professors.
Thanks.
Thank you.
Bye, audience.
Yes, and I see the participants online also say thank you to you directly in our check-in box.
Okay. Good.
Thank you so much. Have a nice day to all.
Thank you.
Goodbye.
Bye-bye. I can also exit then.
Yeah. Thank you. Thanks for your time and patience.
Okay. It was clear. You can follow it. Was not too rapid.
Yes, I think. Okay, so I think we can end our meeting now.
Yeah. Okay.
Thank you. Have a nice day. Bye-bye.
Bye-bye. Bye.